Hello, this is Alana Kaucher. I'm going to be presenting to you applying theoretical knowledge and skills of pharmacology with neurologic and neuromuscular agents to patients with chronic, acute, critical, and mental health care needs. This is a two-part lesson, and this is part one. This first category of drugs that we're going to discuss are the CNS stimulants. There are numerous drugs that can stimulate the central nervous system. The major group of stimulants include amphetamines and caffeine, which stimulate the cerebral cortex of the brain. Analeptics and caffeine that act on the brainstem and medulla to stimulate respirations. Anorexiants, such as diethyl are thought to suppress appetite by stimulating the satiety center in the hypothalamic and limbic areas of the brain. Some medically approved uses for these drugs include ADHD or ADD, you're going to hear it both ways, narcolepsy, and reversal respiratory distress. Attention deficit hyperactivity disorder, ADHD, also known as ADD, the pathophysiology, dysregulation of transmitters, serotonin, norepinephrine, and dopamine. Epidemiology, it usually occurs in children before age 7 years. It is more common in boys. If girls are going to be diagnosed with ADD, it usually occurs within their teenage years. What are the characteristics? So what are you going to assess? You're likely to see these patients that present with inattentiveness, inability to concentrate, restlessness, hyperactivity, and an inability to complete tasks, as well as impulsivity. Narcolepsy. Characteristically, these patients present with recurrent attacks of drowsiness and sleep during the daytime. It's not just, I'm tired, I want to go to sleep. These are people that are unable to control that sleep. They fall asleep while driving, they fall asleep talking, they fall asleep eating, and they fall asleep standing. Now we're going to talk about some of these drugs to treat these conditions. Amphetamines, their action to stimulate the release of norepinephrine and dopamine. They usually cause euphoria and alertness. They stimulate the release of the norepinephrine and the dopamine, but do come with the side effects and adverse reactions. Tachycardia, palpitations, hypertension, sleeplessness, restlessness, irritability, anorexia, dry mouth, weight loss, diarrhea, constipation, and impotence. Amphetamine-like drugs for ADHD, methylphenidate, Ritalin, and dexmethylphenidate, Focalin. Those two are very common drugs that we use for treating ADHD or ADD. They increase the attention span, they increase cognitive performance and memory and reading. They decrease the impulsivity that comes with the disorder and decrease the hyperactivity and restlessness. Amphetamine-like drugs for narcolepsy are used. We can use Ritalin for these patients. The modafinil or Provigil is also a medication that's frequently used. Its action is not fully understood, but it aids in increasing the amount of time narcoleptic patients feel awake. Methylphenidate, Ritalin, its action is to modulate the serotonergic pathways by affecting changes in the dopamine transport. Its uses is for ADHD, for the fatigue, and for the narcolepsy. Amphetamine-like drugs are favorable and considered more effective than amphetamines because amphetamines have a higher potential for abuse intolerance. There are interactions that you need to be aware of. Caffeine may increase the effects. There may be decreased effects of decongestants, antihypertensives, and barbiturates. And I think a very important thing that we need to consider is it may alter the insulin effect. Caffeine, when used in conjunction with Ritalin, can increase the stimulatory effects of irritability, nervousness, tremors, and insomnia. Again, the side effects, these are the things that we were going to want to teach our patients. Side effects, adverse reactions, tachycardia, palpitations, dizziness and hypertension, sleeplessness, restlessness, nervousness, tremors and irritability, increased hyperactivity, anorexia, dry mouth, vomiting, diarrhea, weight loss, and thrombocytopenia. Let's look at our nursing process. What are we going to assess? What do we need to do during that assessment? We need to obtain a patient history. We need to get baseline vital signs to compare to future ones. What is your patient's mental status? Obtain labs such as CBCs, their WBCs, and platelets before and during the therapy. Then we need to do some diagnosing. Risk-prone behavior, interrupted family processes, or even deficient knowledge. Then what are you going to plan? What is your goal for this patient? What do we want to see? We want to see a reduction in hyperactivity. We want to see increased attention span. We want vital signs to remain within normal limits, and we want the patient to behave in a very calm manner. We also need to do some nursing teaching. Uh, we're going to cover that on the next slide. And there's also cultural considerations. And always with the nursing process, we're going to finish up with evaluation. We need to evaluate that the plan that we have set for this patient is actually working. So let's teach this. Let's teach. Give before breakfast and lunch. We want to report an irregular heartbeat. Would you want to teach the patient? I find that in nursing we say, you need to report if you have an irregular heartbeat. Well, what is that going to mean to the lay person? Perhaps you would explain if you feel your heart skipping beats or if you feel as if your heart is pounding very fast. Record, we need to make sure that we have the record of their height and weight and growth of children. We want to avoid alcohol and caffeine. Use sugarless gum to relieve a dry mouth. Do not stop this medication abruptly. Taper off to avoid withdrawal symptoms. And this patient may actually also need to go for some counseling to help them to modify the behaviors that they've been experiencing. Ritalin is well absorbed from the GI mucosa and is usually administered twice a day in children. So before breakfast and lunch, that's why I said give or take before breakfast or lunch. Food does affect its absorption rate, so we want to give it within 30 to 45 minutes before meals. There's also a transdermal patch that individuals can wear for up to 9 hours, but you want to have that patient to take that off somewhere around the 3 to 4 o'clock time frame in the afternoon, or else they might experience a little bit of insomnia at night. Now we're going to talk about some anorexiants. At one time, they prescribed amphetamines pretty freely for short-term weight loss use, and that was within a 12-week period of time that it was done. But they had the potential for tolerance, dependence, and abuse, so they were discouraged as weight loss tools. An over-the-counter medication, phenylpropylamine, was ordered removed from OTC meds because of its risk. Young women especially were at increased risk of hemorrhagic stroke with that medication. So most of the anorexics listed on this slide have only mild side effects and are considered safe for suppressing appetite for weight loss. However, patients should be encouraged to try more conventional methods such as behavior modification strategies. Children under 12 should not take these medications, and patients should not self-medicate with anorexiants due to the adverse effects from long-term use. They might experience nervousness, restlessness, irritability, insomnia, heart palpitations, and hypertension. And I think if you walked through any aisle within a pharmacy area at Walmart, you would see that they have an amassed amount of over-the-counter weight loss aids. Analeptics are CNS stimulants. Their primary use is in the neonate for stimulation of respirations. Neonates who are administered daily doses of therapeutic caffeine will present as irritable babies. Caffeine, probably the drug of choice for most of us. When consuming more than 300 milligrams of caffeine, though, it can affect the CNS and the heart. Patients may experience dysrhythmias and even convulsions. Have you drank so much coffee during the day that you thought, oh, my heart is either pounding out of my chest or palpating like crazy? Coffee, chocolate, and cold relief meds can cause psychological dependence. The half-life of caffeine is approximately 5 hours. Patients with liver disease, patients taking oral contraceptives, or who are pregnant will experience prolonged half-life with caffeine. Over-the-counter analeptics also include no-dose and Vivarin. Doxapram is used to treat respiratory depression caused by an overdose, pre- and post-anesthetic respiratory depression, and COPD. It is a medication that is administered IV, and the onset is typically within 20 to 40 seconds with a peak action at 2 minutes. Side effects are infrequent, but with an overdose, the patient may experience hypertension, tachycardia, tremors, spasticity, and hyperactive reflexes. Epilepsy, a seizure associated with epilepsy results from abnormal electric discharges from the cerebral neurons and is characterized by loss of disturbance of consciousness as well as convulsive movements. The cause is relatively unknown. It may be related to trauma, anoxia, infection, stroke. Some isolated seizures are due to fever, electrolyte, or acid-base imbalances. The international classification of seizures, we're going to start with generalized tonic-clonic grand mal. It is the most common. The patient will have generalized alternating muscle spasms and jerkiness. The absent petit mal is a brief loss of consciousness, 10 seconds or less. It usually occurs in children. Partial, they're going to have some psychomotor problems, repetitive behavior, chewing or swallowing motions, behavioral changes, and motor seizures. So now we're going to talk about the anticonvulsants or anti-epileptic drugs. Um, Depending on the drug, it can work by suppressing abnormal neuron firing in 3 different ways. The first way would be by suppressing the sodium influx through the drug, binding to the sodium channel when it is activated, prolonging the channel inactivation, and thereby prevents neuron firing. One of those drugs will be Dilantin, valproic acid, topramate. There's also a second way. It suppresses the calcium influx. And what this does is it prevents the electric current generated by the calcium ions to the T-type calcium channels. Again, that drug would be a valproic acid. You would also have ethosuximide. It would be a second drug that does that. Now, we have drugs that can also either enhance GABA or promote GABA. And that we're looking at barbiturates, benzodiazepines. Uh, those will promote GABA release. I'm sorry, excuse me, those enhance it, but gabapentin or Neurontin promotes its release. So now we're going to talk about Subdilantin. It is one of the most commonly used anticonvulsants. It is contraindicated in pregnancy. The drug has a narrow therapeutic range. It is slowly absorbed from the small intestine. It is a high protein binding drug. The half-life of Dilantin is approximately 24 hours, but it can range from 7 to 42 hours. The severe side effects of hydantoins include neurologic and psychiatric effects such as slurred speech, confusion, and depression. We also have thrombocytopenia, leukopenia, gingival hyperplasia. These patients on hydantoins for long periods of time might also experience some elevated blood sugar and some less severe side effects of nausea, vomiting, constipation, drowsiness, headaches, alopecia, and nystagmus. Dilantin does have some precautions with it because we have some drug interactions that can occur. There could be some increased effects of Tagamet or sulfonamides, decreased effects with folic acid and acids, calcium, sulforaphate, anti-neoplastics, antipsychotics, primrose, and ginkgo. Ginkgo may actually decrease the effects of dilantin. It also could have some decreased effects of anticoagulants and oral contraceptives, antihistamines, dopamine, and theophylline. Dilantin may inhibit insulin release, and that's what causes our increase in glucose levels with these patients. Nursing process. We always need to go through this. What's our assessment? Make sure that you obtain a health history, including all current medications and herbal products that are used by this patient. During your assessment and history, make sure you find out times the patient typically takes the medications. We need to check urinary output. We need to look at lab values related to renal and liver function. Diagnosing, we're looking at a risk for injury, impaired oral mucous membranes, imbalanced nutrition, and risk for falls. What are we going to plan? What do we want to see? What are your goals based off your diagnoses or patient diagnosis? Free of seizures, free of injury, adherence to the medication regimen. Nursing interventions are going to be listed on the next slide, and we'll talk about those. But after you work through your nursing process for the patient, you always end up with an evaluation time. Did your plan work? If not, what will you modify to enhance your patient's understanding? Nursing interventions. What are we going to teach this patient? If they're having to take an oral suspension, it needs to be shaken for 5 minutes. We want to monitor the serum drug levels. We want to protect from environmental hazards, and we probably need to put some precautions on these patients depending on the type of seizures they're having for driving. Warn female patients taking oral contraceptives to use additional contraception. What else are we going to do? We want to warn the patient to avoid certain herbs, alcohol, and other CNS depressants. We also want to warn them not to discontinue this medication abruptly. The patient will need frequent oral and hygiene and dental checkups. Diabetics need to monitor the glucose levels. Tell each patient to take the drug at the same time every day, the same time. Warn of the harmless pinkish red or brown urine. Teach patients to report sore throat, bruising, nosebleeds. Encourage them to wear medical alert identification. For the oral hygiene, use a soft toothbrush. We want to prevent gum irritation and bleeding. Sore throat, bruising, and nosebleeds may be indicative of an adverse reaction and a blood dyscrasia. Barbiturates. Phenobarbital is a long-acting barbiturate. It is still prescribed to treat partial seizures, grand mal seizures, and acute episodes of status epilepticus, meningitis, toxic reactions, and eclampsia. Barbiturates reduce seizures by enhancing the activity of GABA. Risk associated with this medication are sedation and patient tolerance to the drug. We don't want them to stop it abruptly. They must have a gradual discontinuance. Okay, succinimides. The drug of choice, Xarelto or ethosuximide, is the one of choice for this class of drugs. This group of medications is used to treat absence or petit mal seizures, and at times it's used in a combination with other anticonvulsants. We're looking for a therapeutic serum range of 40 to 100 micrograms per ml. Some of the adverse effects that we are watching for with this medication would include blood dyscrasias, renal and liver impairment, and systemic lupus. The next drugs that we're going to look at are the benzodiazepines. Clonazepam, chlorazepate, dipotassium, and diazepam. Clonazepam is effective in controlling petit mal or absence seizures. Tolerance, though, may occur within 6 months after drug therapy starts. Chlorazepate dipotassium is administered in adjunctive therapy for treating partial seizures. Diazepam, primarily prescribed for treating acute status epilepticus. It must be administered IV to achieve the desired response. Short-term effect, thus other anticonvulsants need to be given during or immediately after administration of diazepam. All right, Iminostilbenes, carbamazepine uh, is a drug that falls within this category, effective in treating refractory seizure disorders that have not responded to other anticonvulsant therapies. It's used to control the grand mal and partial seizures and a combination of these seizures. It's also used for psychiatric disorders such as bipolar, trigeminal neuralgia, and alcohol withdrawal. The therapeutic serum range is 5 to 12 micrograms per ml. An interaction may occur when taken with grapefruit juice, so it could cause a possible toxicity. Valproate, or valproic acid, is used to treat petit mal, grand mal, and mixed types of seizures. Safety and efficiency of this drug has not been established for children younger than 2 years of age. Caution in patients with liver disorders because hepatotoxicity is one of the possible adverse reactions. We need to monitor the patient's liver enzymes. We want to look for a therapeutic serum range of 50 to 100 micrograms per ml. So, anticonvulsants and pregnancy. Seizure episodes increase 25% in women with epilepsy who are pregnant. Hypoxia that may occur during seizures places both the pregnant patient and the fetus at risk. Many anticonvulsant drugs have teratogenic properties that increase the risk for fetal malformations. Anticonvulsant drugs tend to act as inhibitors of vitamin K and contribute to hemorrhage in infants shortly after birth. They also increase the loss of folate in pregnant patients. We have to monitor their serum levels closely during pregnancy because seizures tend to become more frequent due to their increased metabolic rates. Anticonvulsants and febrile seizures. Seizures associated with fever usually occur in children between ages 3 months and 5 years. Epilepsy develops approximately in 2.5% of children who have had one or more febrile seizure. Prophylactic anticonvulsant treatments such as phenobarb or diazepam may be indicated for high-risk patients. Valproic acid should not be given to children younger than 2 years because of its possible hepatotoxicity. Finally, we're going to talk about anticonvulsants and status epilepticus. It's a continuous seizure state. It is a medical emergency. What are we going to use for it? We're going to use some diazepam. We're going to administer that IV. We're also going to give the patient some lorazepam or Ativan. IV administration of Dilantin. For continued seizures, we want to give some Versed or Diprivan. That is the end of my presentation. You will have a discussion question associated with this week's PowerPoint presentation.